a great privilege to introduce Dr. Federico Bruno from the San Salvatore Hospital in Italy, who will be talking about oxygen metabolism mapping in multiple sclerosis. Looking forward to that.
Thank you for the introduction, and good afternoon, dear colleagues. I thank again Sercare for organizing this summit that is a unique occasion to meet colleagues and exchange ideas. The topic of my talk is quite a niche and different topic about perfusion in stroke and oncology, but it's something that I think it may really have a great impact on the understanding of the pathophysiology of multiple sclerosis and potential impact on the treatment. We know about the pathology of multiple sclerosis that is characterized by complex autoimmune remyelination with inflammation and degeneration. What now know is that multiple sclerosis is changing in what is the treatment of the pathology, what is also the epidemiology of the pathology. We see much more increasing cases in some areas in the world that were not so frequent previously, and also in many age. The core phenotypes are different, but also in these cases there are different emerging phenotypes with accumulating evidence that the clinical course of the pathology can be considered as continuum. We know that this mainly secondary to, of course, also the advantages in the treatment of the pathology. So what was before the natural history of the relapsing and the progressive accumulation of disability in the pathology with acute attacks. Together, we face a new natural history of the pathology with the current treatment, with a much more silent progression that makes the impact of imaging much more important in understanding what is actually going on in our patients. Of course, since the inclusion of McDonald criteria, multiple sclerosis remains a cornerstone of the diagnosis and follow-up of the pathology, especially for what is the morphological evidence of the lesion load in fluid-sensitive sequences and the accumulation of white matter lesion. We know that white matter lesions are correlated. It's an important basic biomarker of multiple sclerosis, especially not only with the clinical course, but also with the progression, for example, for clinical isolating syndrome to overt multiple sclerosis. Another emerging and important biomarkers is the atrophy that is now a clear consequence of the pathologies, that it's not only inflammation but also neurodegeneration, not only of the white matter but also gray matter, and more importantly is strictly associated with the physical and the cognitive decline and disability of the patients. So we are facing in increasing importance of finding important biomarkers, not only for diagnosis but also for monitoring the disease activity, and also with new treatments for evaluation of the treatment response and prediction. What is the evolution of the pathology. And of course, conventional MRI is much insensitive for what is the CNS tissue outside of the MS lesions. For this purpose, we know that are emerging many advanced MRI sequences, including the evaluation of, for example, of mapping on T2 and T1 relaxation for the evaluation of the white matter, but also biomarkers of blood-brain barrier disruption and remyelination. But going to the core of the topic, what we know about the perfusion in multiple sclerosis. We know that from clinical and preclinical studies that hypoperfusion in multiple sclerosis happens in both gray matter and normal appearing white matter, even in the early stages of the disease and in all phenotypes. Some pathophysiological mechanism proposed for this is the elevation of endothelin-1 with vasoconstriction and a reduced cerebral vascular reactivity with an impaired vasodilatory response. There are also some evidence that, for example, for the purpose of potentially new treatment, the use of endothelin blockage can maybe increase the perfusion in this patient, and this may be a target for novel treatment strategies. What is actually going on in this in multiple sclerosis is this virtual hypoxia state. It means that the oxidative damage due to inflammation can cause a reduction of mitochondrial function. So despite a normal perfusion in the brain, there is a reduction of the utilization of oxygen. On the other hand, the hypoxia can also have a direct effect on the reduction on the perfusion with a more impairment of the metabolic demand. This is a chapter published in January this year, where it focused the attention of the change of the paradigm of the pathology towards the metabolism problem in multiple sclerosis. And most of the metabolic disturbances that happen in the pathology are driven by abnormal perfusion. With the standard MRI technique perfusion, we can evaluate the parameters that we know, that CBF and CBV and transit time, that can be framed some difference between active and chronic stages of the disease compared to normal white matter. But what is actually important is the quantification of the metabolism, so the oxygen extraction fraction, that is the purpose of our study. To date, the standard we know is PET. With other imaging technique, for example, MRI, we can derive this parameter using the susceptibility mapping techniques. It means measuring the paramagnetic susceptibility shift between the vessels and the neighboring brain tissue. This technique is very used in many clinical studies, but are some modeling assumption. It means that measure the face images through a simple cylindric models. So what is outside of the cylindric model may underestimate or overestimate the OF, and also that does not consider the microstructure outside of the voxel, including the vessel and the tissue. So, for example, can lead to this estimation of what is, for example, the white matter compared to the gray matter. But let's go to some evidence in the literature. This is a study evaluating 22 patients compared to healthy control using the KQ method and the arterial spill labeling for perfusion. As you can see from the graph here, the study evaluated a negative correlation between what is the lesion load of the pathology and the global gray matter perfusion, and as well as the CMRO measured using also end-tidal O2 via the face mask for patients. But at the same time, they show a normal CBV. This means that actually there is no reduced perfusion of oxygen, but actually maybe a reduced capacity of utilization of oxygen metabolism. Moreover, there was no significant correlation with the lesion volume and also with the clinical endpoints. Another evidence in the literature in which the CMRO was calculated to the fixed principle, so measuring the CSF together with the hematocrit. And the results of the studies, as you can see, show significantly lower CMRO2 in MS patients compared to healthy controls, and also no significant difference in CBF. So again, once again, an uncoupling between what is perfusion and what is metabolism. Moreover, there was no differences in brain volume, so in these cases was not driven by brain atrophy. And other studies focus on the different metabolism at the level of the lesion, so no global perfusion of the brain. For example, in these cases, 80 chronic active lesions that we know that are very clinically important for what is the progression of the disease were mapped with the oxygen extraction fraction, again in 22 patients. And in these cases, it was evaluated a reduction of the oxygen extraction factor at the core of the lesion compared to the peripheral rim. And this was an instrumental evidence of what is an increased inflammatory activity in chronic active lesion compared to the lesion core. In this other study, the same authors also documented a reduction of the oxygen extraction factor, not only in the normal appearing white matter, but also in the deep cortical and deep gray matters of the lesion. Another very important study on evaluation of the metabolic differences in different type of multiple sclerosis is this one that divides lesions into active lesions that capture gadolinium, chronic active lesions that are the so-called PRL lesions, and also chronic inactive lesions that are negative to in QSM, and remyelinated lesions that show an ISO or hypointense signal on quantitative susceptibility imaging. Evaluating this different lesion with the QSM technique and evaluation of oxygen extraction factor, they found that as you can see here, the oxygen extraction factor in all types of the lesion was significantly lower than the normal apparent white matter, and this is a sign of the disruption of the metabolic activity in the MS lesion. But in some patients, they did also follow up, and they show that some lesions evolved to chronic PRL lesions. Some lesions evolved to chronic inactive lesions, and some lesions show features of remyelination. As you can see here, the lesions with remyelination showed an increase of the oxygen extraction fraction compared to chronic inactive lesion, where there was a reduction of the metabolism of the lesion. So the OF, again, can be an important biomarker for what is a differentiation of the multiple sclerosis lesion, but also metabolic index of the disease activity and the tissue damage. Moreover, it can be also another biomarker that can be also much more sensitive than PRL for the switching of the activity of the lesion, for example, in inactive lesion or chronically active lesion. Another key feature of multiple sclerosis lesion is the possibility of remyelination, so a regenerative response secondary to the myelin loss with the generation of new myelin by oligodendrocyte. We know that this this remyelination is strictly dependent on the metabolic features and can be, of course, worsening with the clinical outcome. In this study, the authors evaluated 22 patients with gadolinium-enhancing lesion, again with the same technique of QSM and TDO mapping for the evaluation of the white matter. And as you can see here in the results, there was an increase of the oxygen extraction fracture at the follow-up at 3 months and 12 months in the active lesion. And these findings were suggesting the possibility of remyelination at the level of the lesion with an energy-demanding process, so with an increase of the metabolic demand of the lesion. Of course, this study was only focused on gadolinium-enhancing lesion with a relatively shorter follow-up. In our preliminary experience, so far we evaluated 13 patients with relapsing remitting multiple sclerosis that perform gadolinium for surveillance of PML, so not only acute lesion, but in most of cases chronic lesions. And for now we are providing a comparative evaluation of gadolinium, SVI, lesion volume, and OF maps. I show you one identified cases in which we have an active lesion in 2024, follow up 2 years later, the lesion of the size of the lesion is stable. There is a reduction of the contrast enhancement. At SY, there is no PRL at the contrast of the lesion, but in the OF maps, we can see an increase of the OF relative to the core lesion. Of course, we are still doing quantitative measurement of the lesion and rolling of the controls for the definitive results. But this is a clear evidence of the feasibility of the perfusion in the analysis of OF with CERCare. That is one of the first application with the SCMRI compared with the previous techniques. So coming to conclusion, the key message of my talk is that multiple sclerosis, it's strictly associated with disorders in what is the cerebral perfusion and the metabolism, not only at the level of the lesion, but also at the level of what is the normal appearing white matter. And this is strictly associated with the pathophysiology of the disease. What is important that these metabolic disturbances can appear before the evaluation of for example, gray matter atrophy or also new lesions. So this can be potentially a very sensitive biomarker for disease monitoring. And in particular, OF has been documented such as a promising biomarker with the previous MRI techniques, and directly with MR perfusion can be evaluated also in a clinically feasible environment. Since now, as you see from the literature, the experiences are quite heterogeneous in terms of age, disease duration, ADSS, number of patients, also limited reproducibility of the technique. So we need further studies. We need to get involved in understanding exactly the pathology and the perfusion in multiple sclerosis, especially for the longitudinal monitoring of the disease and also the impact of the treatment. Thank you.
Thank you, Dr. Bruno, for taking us into this next aspect of capillaries, namely that we heard about until now how ischemia looks different when we take capillaries into account. But here we face that there are diseases that we don't consider, vascular, but where energy metabolism is still a big issue. And I think you made that very compelling argument. Are there questions? Otherwise, I have one because I'm very excited about capillary function in neurodegenerative diseases, and we actually try to do this in MS as well. And I had one question: do you see it as feasible to combine, blood-brain barrier permeability measurements with, the DSC as you did here? Have you considered that, or how do you get the leakage information into your studies?
I think in our experience, the major limitation was in the evaluation of what is also the global perfusion parameters compared to previous studies. And yes, there is also the problem of the possible contribution of the blood-brain barrier, but we need to study more active lesion because in our experience we always studied chronic lesions.
Thank you very much. Let's give another hand to Dr. Bruno. Thank you so much.